Maybe you can just tell Isaac to advance.
Yeah, you can advance, Jess. Yeah. It started already in 2004. You see here on the left the European Perinatal Health Report, which in 2004 for the first time showed that the Netherlands had one of the highest perinatal mortality rates in Europe. And for our system, which we thought, of course, was excellent and we were the best, that was a shock. And as any brief response was originated, the first reaction was denial. And then, of course, the other reports came, and we had to admit that we didn't do a good job. As a result, of course, as a result, of course, in the middle, there's a report of a government-instituted committee which made a good start, did a lot of recommendations of how we should change our obstetric care to improve and have lower perinatal mortality rates. And on the right, that's the report in 2010. And the good news was we succeeded in getting the rates down. The bad news now is that it is stabilizing, and we're still about in the middle of other European countries we are compared with. But the main question was, of course, is how do we improve our care to prevent perinatal mortality and, of course, better care for parents. First, of course, is but we put a lot of emphasis in, is if you want to talk about improvements, you have to talk about causes first. You have to have a proper registration, and you want to know your numbers. And this is just, of course, more than 80 systems of classifying perinatal mortality. But, there and there's a huge debate about causes or relevant conditions, not going into that at the moment. But, congenital malformations, placental problems, preterm birth, infection, other are actually, let's say, the medical things that you can underlie as causes for stillbirth. But what we found, of course, is, and it's hardly mentioned, that substandard care factors where just the caregivers didn't do a good job, where at least in 10%, but up to 20% of cases, there were errors made in the care which contributed to or led to the perinatal mortality. And that's difficult. It's more often to contribute. You got risk factors, and most of the time, many small things make big disasters. There's hardly just one particular cause for the perinatal death, and that, of course, is also the origin of the discussion on the different classification systems. One thing is obvious, that all those relevant conditions, including the substandard care factors, are all more prevalent in underprivileged populations. And that there are ethnic groups, but also lower social groups, where we talked about all morning. I show you one slide in the end of the presentation. In asylum seekers in Holland, the perinatal mortality, the complications of pregnancy are up to 10 times higher than in the normal Dutch population. Thank you, Alex, for showing this as well. But I have another arrow there, because in the Lancet series there, we showed that the Netherlands had the largest reduction in stillbirth rates over those years, and we're very proud on it. And the obvious question is, what did you do to achieve these numbers? The honest answer is, I don't know. To be honest, because of the committee and the recommendations, there were several. There were up to 15 recommendations we had to work on, and it's always difficult to address just one thing as a cause for that change. But there were several elements working together from several sources. One, of course, we still have a 17% home delivery rate with independent midwives. And one thing was truly obvious, that there was a better cooperation between the primary care midwives and gynecologists in hospitals. There were faster referral and action protocols in case of obstetric emergencies. There were awareness of decreased fetal movements. Actually, I wrote the first combined guideline with the College of Midwives and gynecologists on decreased fetal movements in Holland. The fetal monitoring, also mentioned, was improved by education. Another effect, of course, is an higher uptake of prenatal screening and higher activity of programs, and actually more decisions for termination of pregnancy early in pregnancy in case of severe congenital anomalies, which, of course, don't get into the statistics and will drop your numbers. we have a nationwide policy of not putting more than one embryo back. So the multiple gestation rate dropped immensely. And of course, that was my thing, we invented the structured and we implemented the structured perinatal mortality and also morbidity audits in all obstetric units in the Holland. There were about 75 at the moment. And we organized the group, and I went to all 75 units and trained multidisciplinary groups in doing those audits, which identified issues to improve. And then, of course, in the next year or so, implementation plans came on. So the local groups identified the recommendations and tried to implement it in their local collaboration unit. So that was a foundation we founded. It called Perinatal Audit in Holland. It was a joint effort. It was of the government and the professional colleges, the pathology, the midwives, the general practitioners, pediatricians, gynecologists were all involved. The government put money in there, and we had a 3-year focus on several topics. So the first 3 years was the term perinatal mortality, and there was a focus on perinatal asphyxia. Later on, late preterm deaths were added. Also, pediatric topics were added, like hyperbilirubinemia. And now, these 3 years, we had 2 other topics there, early neonatal collapse. And what is more and more increasing is that couples request for requests for care outside guidelines, which is a huge problem now getting into Holland. You know, people after cesarean want to deliver at home in the garden and whatever. Yeah, you are laughing, but that's a real issue. So we made reports, we made fact sheets, and we did recommendations for improvements, and they were implemented. Well, an audit is, of course, analyzed. It's not a medical review. That's different. You're all used to medical reviews about how a case went on and whatever. But an audit is looking at the processes, what happened, and if something didn't happen, what went well. You should not forget to mention what went well, but also what should have been done differently and how came that about. This is a root cause analysis. It's asking why, until you can't get any further, and that's your basic cause. And of course, you're measuring practice, you compare cancer standards, you identify opportunity for improvement, you suggest change, and you implement that change. And that's easier said than done, because implementing change is one of the most difficult things in healthcare. You know, especially doctors are very resilient to change, because one way or the other, they don't want to admit that they have done it wrong all the years before. But that, the concept of increasing knowledge is difficult. And then, of course, the audit cycle goes again. So, we want to improve the quality of care by an audit procedure, in a review of what happened, and to evaluate the care process. So we have an analysis of substandard care factors we want to learn. And the main question is, where should our care have been different? Where did it deviate from protocols of normal care? And of course, also, that happens, of course, have there been any medical errors made? There are multidisciplinary groups. They choose their own cases. They're all anonymous, so no patient data or no names of people are involved. And after presentation of the case, the group is deciding what should have been done differently and try to analyze how that came about. That's always then the issue of sensitive issues about things that have done horribly or possibly have done wrong. And of course, talking about medical errors is scary. It's difficult, sometimes terrifying. People are afraid for litigation issues, and even sometimes it's forbidden to talk about it. So the challenge is to get that group in such culture and such atmosphere that these things can be discussed without shame and blame. Because the basic mantra is we want to learn this. Everybody makes mistakes. And it's not that every day that in the morning we stand up, so now we're going to kill a few babies today. No, of course not. That happens. Many small things make big disasters. But the question is, and we should do an inquiry, is how did that came about and what can we do about it to prevent it. And my adagium is also that if you find something that was causative for the death and it can happen again tomorrow, you should solve it yesterday. So, how do we talk about medical errors? And that, of course, is built with emotions. That is, of course, okay. How do you build a respectful, friendly, open-minded, unthreatening climate? Non-judgmental, focused on behavior, observe facts. And one of the things we came about is that you need an independent chairperson who is trained to guide you through that meeting. And the other thing is that you need to train those groups, because it's not normal. It is not so much normal. It is not obvious that everybody is used to talk about these kind of things in these groups. You need to train them in advance to be prepared for talking about difficult issues. So the results were, after training all of the Netherlands and getting those audit meetings, and actually from 2009 onwards, there's still 3, 4, 5 times a year in every hospital. The average number of people there is about between 20 and 50 people, midwives, nurses, doctors, pathologists, pediatricians, sometimes even ambulance personnel, so first responders if it's necessary. And the independent, respected chairperson is absolutely essential. So we train them separately. They have separate training for those chairpersons. But those teams need to be trained in advance. The methodology and the communication, that's not rocket science. We took that from all kinds of psychological things, but that's not difficult. But those sessions are quite sometimes heavily covered with emotions, and that's fine as long as there's peer support for people. And nowadays, usually it's not necessary that the people involved, the caregivers involved, make themselves known. But actually, at the moment, it's more the rule than the exception, that people say, "Yeah, I was there, and at that time, my decision was made because of this and this and this." And how afterwards, yeah, that was a wrong decision. But what was the basic thing that made me do that? Proper preparation for each case. That takes a lot of time. It also takes a lot of personnel. And the other thing is that those improvement points, they need to be implemented, because everybody, you need that positive vibe to sustain that quality cycle. If you come next year there and nothing's changed, then the motivation of people, of course, is gone very quickly. The challenges were mainly organizational. How do you get the people? How do you get the meetings together? Some funding. You need some funding for getting the training done. As I said, we are very used to talk about medical reviews, but not so much about the processes. Always an interesting example that, we are very bad at documentation in the patient notes. Even when things go wrong, we hardly write things down. And there was a certain case that, there was the women in labor, and the nurse had at the telephone very difficulty trying to get the consultant in, because he was somewhere else and we're having dinner or whatever. And that's not in the notes. But the lady who's lying there in labor heard the conversation, and she doesn't lie. So that kind of information is essential to get a proper view of what happened and where the possible delays were. But the biggest thing, of course, is, and still one of the reasons it's still ongoing, is still a lot of people are motivated, is that the eternal motivation is still present. You have to be only a couple of times at the birth of a deceased child, and said, "I don't want this ever happen again." Any tool should be simple, so you should evaluate, give feedback, but you should celebrate the successes. And we got a lot of examples from that. One unit who didn't, for instance, monitor the maternal heartbeat together with the CTGs. They put it in, they called it Measure Mama also. They had candy to do it and whatever, made a huge project out of it, and was very successful. And at the moment, of course, over the last years, we asked parents, of course, also for their input, and discuss how, in the best way, to give them also feedback of the results of these meetings. That's not a role for the audit group because it's anonymous, but it's a role of the primary caregiver for the parents themselves. So, conclusion is, one of the how do we reduce stillbirth? We should reduce risk factors. There's sometimes care issues. Sometimes you need food medication, treating hypertension, but mostly, actually at the moment, I think it's mostly public health issues. And that is where the underprivileged groups in your society come in, and the smoking, for instance, and the maternal age, lower social class. Yeah, that are other things which, for the medical point of view, are difficult maybe to intervene. Well, one last thing, we did a special study on suboptimal factors in care for refugees because they had, as I said, up to 10 times more pregnancy complications. And what, of course, you see there is that those groups that influence the decision to seek care, they have low sometimes healthcare abilities or knowledge about the healthcare system. So there's a 3 delays model. Is the care setting, the accessibility of the services, and the factors that influence a woman's ability to identify and reach appropriate medical faculty, and of course, it's the quality of care. And one of the things which shocked me most is that a lot of caregivers don't like these patients. Just let's say it honestly. And in that way, they find it a problem of giving the proper care to these underprivileged groups. And the conclusion of this was, so we took a lot of audit cases from the national database and looked at the specific at the refugee population, and the number of suboptimal factors was dramatic and alarming. And well, there's now, of course, as a consequence, projects underway to see how we can change this. So prevention, proper registration, we should know where we talk about. You should meet your numbers. You improve your quality of care, and you should reduce your risk factors, and you should do audits. Thank you.
Thank you so much, JJ. I'm Jess Page. I am a local here to Utah, and I've been here a long time. And I am fortunate today to get to speak a little bit about perinatal audits and where the gaps are from a United States perspective. As has been a theme throughout the day, the United States is a little fragmented in a lot of ways. But in regard to how we handle our fetal deaths or stillbirth tracking is only one of them, and it's a big one. So my disclosures are that I don't really have any traditional disclosures, but as many of you know, I feel really passionately about getting patients an appropriate evaluation for stillbirth and see that as sort of essential to this overall focus. And that is part of the issue with perinatal audit. If you don't know what happened, if you don't have a cause of death, it's really hard to figure out how we can improve things. So that's, we will talk a little bit about that in part here. And as another sort of framework for this conversation, you know, in learning about your experience, where you come from and developing this wonderful system in which you can actually study, you know, cases of stillbirth and figure out system-wide targets. I sort of see the U.S. system and office locally as part of that, is at kind of the infancy of this, given our proximity and lack of a structure. So currently, there is not a uniform system in the United States for tracking causes. I should say there's not a uniform system for evaluating cases of fetal death, where all cases are cataloged, studies, areas for care improvement identified. That's not something that happens on a nationwide level. There are different policies in different states, but many states also, probably most states, lack a uniform system for this as well. In Utah, we do have our perinatal mortality review, but those programs really focus on maternal mortality, which is obviously very important, as well as infant mortality, those deaths that occur in the first year of life. And there's not really, there is no monitoring system or formalized mechanism for evaluating and analyzing fetal deaths. We do have one mechanism in place that I would be remiss not to point out that is great that our state does engage in, and that's called our SOARS program, or Study of Associated Risks of Stillbirth. And this is a program that our state has ongoing, in which families are sent a survey following the loss of a baby at 20 weeks or greater. And they study prenatal and postnatal care, social support and stress, grief and bereavement support, services offered by the hospitals after stillbirth occurs, tests that may have been offered to the family, any other maternal exposures, chronic health conditions, and then also insurance information. And so this is a great source for information on families that have experienced stillbirth, but is of course, the patients also need to fill this out, send it back, and it's sort of a limited view. It really does not take into account all of the medical data or a systematic approach for reviewing it. So currently, we do not have a formal process for reviewing the results of a stillbirth evaluation with subsequent family counseling regarding what did we find, what may have happened here, what could we do differently in the future. And if we can't even do that for individual families, doing that for a population is not possible. So this is sort of where I see the gaps coming, in my experience in stillbirth care and research and quest for care improvement. So as we know, we start with the stillbirth, and then after that, we need to get to effective care and counseling. And this is where one of the first gaps comes up: having excellent provider and patient education and support. Because this is sort of that first critical piece. We need to take care of our patients. We need to give them the appropriate tools to understand what happened. And as many of, probably everybody here knows, that whether you've been on the patient side of this equation, the provider side, this takes practice, this takes knowledge, this takes time. This can't be rushed with families. And depending on where you are, you may or may not have a lot of tools and support for getting this done, for providing that excellent care to families going through this and advising them on the appropriate tests to help them understand what led to my baby passing away. That's the first gap that we're working on. And then, so we get our evaluation complete. We then need to review it in a systematic way. We need this formal fetal death audit. And so I kind of think of an audit in terms of these individual patient cases with the aspirational goal of a population level audit of causes and targets for prevention. We need people to then take this information for every family that has this happen to them and go over it. Figure out, what could we have done differently? What should we do differently in the future? See if we have any ideas about what may have caused the death of their baby and help provide some closure to those families. And then that helps us with, obviously family counseling, as I just said, giving them some effective risk reduction strategies and things to think about in the future, if that is in the cards for that person. And all of this, I feel, is sort of circular as well, because if we get to this point, then we can get some stillbirth rate reduction, right? We talked about a lot of the gaps and the disparities in rates of stillbirth. There's gaps and disparities in getting evaluations completed and appropriate counseling. We know this. We have preliminary data from our state showing that patients in rural communities are less likely to be counseled to have a fetal autopsy after delivery, because of those barriers that getting a baby to primary children, having a provider that feels comfortable talking about that. There are so many levels at which we have a lot of work to do. Thinking about the fetal death audit itself, say that we have a patient that does have an evaluation performed, and now we want to do the audit. We want to have them talk with the provider to go over these details. This is another large area for work in our population in our model. Right now, this is contingent upon them having a care provider that can connect them with one, usually me, Bob, or Nate. That's usually about it. Someone in maternal fetal medicine or obstetrics that has interest and experience in doing cause of death analyses. And so there's a lot of disparity there. Many people do not have, wide knowledge of referral pathways for this. Patients may not have access, may not have appropriate insurance coverage, so many things. They additionally, maybe they couldn't get a full evaluation because of associated costs. We are fortunate here in Utah that perinatal autopsy is a covered expense, but sometimes genetic testing and other testing that can be helpful is not covered. And then again, the logistics of getting to MFM for a referral and visit, and just getting this systematic process going. Right now, that really does not exist. That is a huge gap. And again, educating our providers so that they know, this is what we should do after a stillbirth. This is how we take care of families. And this is how we as consultants can help you in the current state. And hopefully in the future, would have a formalized process. Because I see, if we had a formalized process for monitoring all fetal deaths, having an appropriate valuation, systematic review for causes, so that we could then identify these risk reduction strategies, targets for prevention, and then ultimately reduce our rates. I think it all sort of comes together. So as we have no big sister for this, let's talk is short. Thank you.
So thank you very much to both of you for laying out what's possible and where we are right now. We have time for a few questions. I wonder if anybody has got anything that you'd like to ask. Yes, 1 and 2.
I don't mind, but I haven't felt it's good that you participate at Stillbirth with 25% at least, and then 47% at Perinatal, right? And when I read that study, it says a lot about patients. And it seems that we have something there done to help prevent stillbirth at time place. Am I wrong, or is there something?
Thank you so much for asking the question. In that study where we evaluated cases of stillbirth that were well studied and had thorough workups in all of them, and tried to think about, gosh, how many of these could we have potentially prevented with, whether it's a preterm birth risk reduction strategy, perhaps it's enhanced antenatal monitoring. That was sort of the mindset of that analysis. And so I think that's, the fact that up to 25% of cases are potentially preventable, I think that speaks to some of the wider system issues that could, need to be addressed from a policy perspective, getting all patients appropriate prenatal care and screening for placental insufficiency. And acknowledging that our toolkit for that is relatively limited. We've heard about some of the tools today that are in some of the bundles internationally. Things, where we're measuring BUBA, monitoring fundal height as a screening tool for fetal growth restriction, fetal movement monitoring, but then also just access to care and making sure that if we do see signs that can be potentially intervened upon, whether it's for preterm birth risk reduction, whether it's for signs of evolving placental insufficiency, that we can address those. That would definitely be part of what I think is needed in the United States, with just broader access to quality healthcare for our patients. We also are really in need of better risk stratification tools. It's really hard right now to figure out who in our population has a really high risk of a stillbirth and who's at really low risk. And to effectively utilize interventions that can help our patients who are at high risk while not harming a larger population with unneeded intervention.
How do you want? I'm Kyle Bess, and my question is more so for Dr. Page. I just wanted to highlight being a bereaved parent, you having openness to state that there are failures in our system. Having had the medical system personally fail me and my husband, directly causing the loss of our twins, it just gave like a sense of, I just had such a great sense of gratitude for your work, for you being willing to stand up there and say like, okay, we have faults, what can we do to be better? So if you wouldn't mind just speaking to that, like what are some interventions that you and your crew have done or implemented currently here in Utah to avoid situations of loss for parents?
I think in terms of so I think there's kind of two ways to look at that, right? There's population level, like how do we work to reduce the incidence of stillbirth? And I think that really gets to providing like excellent, highest quality, excellent care that we can to everybody that we interact with, and getting that care to all patients. I think that's always one of our goals. And so we do that, as a broader healthcare team, always advocating for that in our facilities. But I think, in terms of my own personal work, I have focused more on families who have experienced a stillbirth. How can we take the best care of them so that we can then understand what happened, take better care of them in future pregnancies, and do what we can to reduce risk. And so to that end, I have been working with in our community to provide better education to providers on how to talk to families about fetal autopsy in particular. I think as one of the most useful pieces of our evaluation, it's also one of the hardest ones for both providers and patients to think about and go over. And so that's been a big target for our care, is educating all of our care providers about how this works, how to interact with families. This group of individuals has been incredible in helping me to spread that word. We're talking to the residents about it this week. So I think there's so many different ways to approach this, but yes, that's one. We also made a new order set, so it's easier for providers in the middle of the night to know, oh, this is what I should put on in order to do this. With all kinds of little things that to that end that hopefully can lead to better changes.
If I can add to that, in my experience, is that parents actually important two things. One, they want that you be open and honest to what happened. And the second thing is that you should do everything possible to prevent other people having it. And so what we do, feedback, is when people are usually moms in postnatal care, whatever, that we feedback to them what kind of things we learned and what improvements. And it can be very simple, that can be in the order of having the right telephone number on the right place, because someone took half an hour to find the right telephone number, or usually it's much more complicated. That it's a chain of events, and then it's very difficult to define good improvements. But we try to feedback that to the parents.
Thanks, guys. With regard to trying to provide better care to underprivileged patients who speak a language other than my very poor example of English, I find translation systems in the way. And when I meet with a patient who doesn't speak English, who's had a pregnancy problem or has a pregnancy problem, that's a real barrier. Does anybody have any genius ideas here?
Well, we were in Holland very lucky that all the translator services were budgeted away. There were budget cuts, but over 2 years ago, fortunately, that came back. I can phone and translate 24 hours a day, and that is a certified translator at any moment, in any situation.
I even think that's a little cumbersome, though. That's one of my points. And I would almost prefer someone come in the room, please. And that's a difficult situation to arrange.
I'm afraid that's all the time that we have, but we've got a lot of things that need to happen in the U.S., clearly, not just related to perinatal audits. So thank you very, very much to this panel.